Welcome to the American Journal of Healthcare Strategy. I'm here with Nancy Edwards today. Nancy, how are you doing today?
I'm great. How are you doing today?
I'm doing fantastic. We might as well just get started. Can you tell me a little bit about yourself and your career?
I'm from Alabama, from Decatur, Alabama. And all my life, I was always what you would call maybe a science nerd. When other kids were playing with more traditional toys, I had a microscope and a chemistry set and things like that. So when I decided what I was going to do for my major in college and what I wanted to do for a career, I decided I would be a biology major, which automatically back then meant that you were a chemistry minor or physics or math or something like that. And I went to school at Vanderbilt. And I wanted to go to medical school. But when you're a biology major with chemistry minor, all you do is spend time in the lab and you take very little you don't do a diverse curriculum. It's all math and science all the time and just the other things that you have to graduate. So what tended to happen was by the end of the fourth year is that, and this was not limited just to Vanderbilt, it was all the schools at the time. So you were having medical students that were exhausted by the time they got to medical school. So after the first year of medical school, they're like, ooh, do we still want to do this anymore? And so one of my friends at the beginning of our fourth year said, why don't we do the business side of medicine and we can graduate, at the end of our third year. It was the beginning of the third year where my friend said this. And so we can graduate and then we'll take our fourth year and get an MBA and we'll do the business side of medicine. So that's what I've always done is I've been fortunate enough to be in the management development program for several very large pharma medical companies. And also I spent a lot of my early career in sales in teaching institutions. And I was very fortunate to have clinicians that basically understood that I wanted to do a good job for them and I wanted to help them develop new products and improve our current products. So they taught me a lot about the clinical aspects of medicine. And so I was a sales manager after I was a sales rep, and then I went into marketing. But the longer I was in healthcare, the more I realized that an MBA wasn't good enough anymore. Healthcare was becoming too specialized. And so I decided to go to George Washington and get an MHA. That's kind of led me to my current path of doing healthcare consulting.
Yeah, that's really cool. And from my understanding, you also founded Edwards Value Based Health in December, so about 2 months ago. Is that correct?
Yes, I actually did that. I had always wanted to have a healthcare consulting firm. And so I decided now was as good a time as any to start the firm. And so it's been very exciting. I've been so touched by the number of people that have reached out to me, either people that I already knew or people that are new connections about how can I help? I have this expertise. Can I help you with this expertise? And you and Cole and the people at the American Journal of Healthcare Strategy reached out and said, we'd love to interview you. We'd love to understand more about what you do and what motivates you and how you do it. So it's been really fabulous. And I've been able to have, contracts with people that I've worked with before and a few new opportunities and a lot of people along the way that have really been very helpful to me as I start my new venture.
Just for our audience, can you sort of describe this organization? I understand it's healthcare consulting, but sort of what goes into it and what are your goals with this organization?
Yeah, so my company actually has two separate parts of the business. The first is around value based healthcare, yellow belt and green belt certification training through the Decision Institute and the Value Based Healthcare Center of Europe. And that's a program that's based on Michael Porter and the team from Harvard's clinical theory on value based healthcare and what it should be. But it also goes one step further to put this theory into an implementation framework and methodology. So when you leave the class, you can actually go out and implement value-based healthcare programs in your institution. So that's one of the things I really like about that program. And in addition, it has a true certification exam for the green belt. So you actually have a green belt certification. And then the other part of the value-based healthcare is that I can also do value-based healthcare consulting. I can tap into the value-based healthcare of Europe global network to get experts in all the various areas of value-based healthcare to help with whatever project that I'm working on. And then the second part of my business is all about using the experience that I've had in the industry, particularly in medical education and key opinion leader management, and also medical society relationships and medical exhibit management, those kind of things. So the business has two different parts, and I do have clients on both sides of the business.
Yeah, that's really, really cool.
It's very unusual. I'll say that. A lot of people are like, "What? Are you crazy? You can't have a business that has two separate arms that way."
Yeah, I guess we can split it up in sort of describing both separate arms. So we can begin with value-based healthcare.
Uh-huh.
How do you define what value-based healthcare is?
Well, that's the problem, I think, in the US is that there are so many different ideas about what value based healthcare is. And so many of them have such negative connotations. For providers, sometimes it means that they're going to work harder for less reimbursement or, less services they're going to be able to provide the patients that the patients actually need. And for the patients, a lot of them feel like maybe they don't have the access to care they'd like. They don't have the access to certain healthcare services that they think that they need. And so that's why I'm so excited about working in value-based healthcare to get everybody on the same page. So the way I define value-based healthcare is healthcare that focuses on outcomes that matter to the patients and their families. Because that's what really matters is what are the outcomes that the patients and the families really care about, and how can we design an efficient and effective healthcare system to deliver that care so that the outcomes are better and the cost is lower. So that's what I really want to focus on with my value-based healthcare training and with my consulting.
I know you mentioned some issues from like the patient side and all that. Do you agree with any of these flaws? Do you believe value-based healthcare might lead to, I guess, worsened care in a way?
I think that when value-based healthcare is done correctly, it can deliver, better outcomes and lower cost. Sometimes initially when you first get started, because you've realized that over the continuum of care. So what you do is you focus on a specific medical condition and you look at the continuum of care and who needs to be involved in that continuum of care in order to deliver the outcomes that matter to patients. So sometimes you may find that you're adding team members or something like that that might initially raise your cost of care while you're improving your outcomes. But the system that, if it's working optimally, will eventually find inefficiencies in the system that'll allow you to basically course correct so you get everything back on the right track because you've eliminated inefficiencies in certain parts of your value-based care delivery, and you can use that money, and still save money, to deliver better care. So doesn't always work out perfectly, but I think that if people are committed to working together and working as an integrated practice unit with the patients and the families and the clinicians and the support team, ideally, that's what should result better outcomes and lower cost.
Right. I know you mentioned previously that a lot of people sort of feel that payers should be involved earlier in the process when developing a value-based healthcare program. What are your thoughts on where the payers fall into the whole continuum?
It was my experience when I first started. I've been doing this since about 2017, 18, when I first became exposed to value based healthcare and became a certified green belt. And then I went on to get a black belt in value based healthcare. So when I first started, it was always that you design, you work with the patients and the families as the clinical team and design the integrated practice unit, and then, have the care delivery system actually working so you can drive out the inefficiencies and lower your costs, and then go to the payers to show them that you have, better outcomes at a lower cost. And one of the other issues that often happens in US healthcare systems that I'll touch on just briefly is that healthcare systems, a lot of them, or most of them actually, don't know the true cost of care. Because they really don't have cost accounting systems. So when they engage in value based healthcare, they can do time driven activity based costing, but it's difficult. So a lot of them develop cost approximation models, and then they take their cost of delivering the care and their outcomes, and then they would go to payers. But recently, as I've been having more in depth conversations with value based healthcare, institutions that are working in value based healthcare have developed incredible programs, but they didn't have payers involved early as they were developing the program. So when they go to the payer with a program that's established, the payers are rejecting, the program as it is. And so they felt like that if they had involved payers earlier in the discussion, or maybe even as they were designing the program, that everybody could have been on the same page sooner. It's an interesting concept, and more I'm hearing that the payers, should be at the table earlier or at the beginning of the process. So I think it's something that's probably we're going to see more and more of.
Do you feel as if payers being early on in the process and sort of going through the whole process of like paperwork, authorization, all these things, do you think that time consuming process could possibly delay certain care that is urgent in a way? Do you think this is mainly a case by case basis, or do you feel like there is still a place for, like, I guess, retro authorizations where the payers can jump in after this critical care is already provided?
Well, and I think that's been the issue actually, is that the care has been provided. And then the payers like, well, you didn't get this authorization, or you didn't fill out this form, or you didn't do this according to our system or our process. So I think actually you just touched on what's been one of the major issues, is that people are providing this great care, but they didn't do it according to the way they should have done it per the payer. I think that's something that'll continue to evolve. And I think there's a lot of really interesting technology that's emerging, especially some of the things with AI that maybe can help with some of these things, and some other, systems that maybe we can incorporate to decrease the burden, because there is a lot of burden on healthcare providers, and especially with all the documentation that's required by all of the different payers. So I'm hoping that we continue to see that evolve, so that we can take advantage of technology and decrease that burden.
Yeah. So we talked a little bit about like sort of the issues involved with value based healthcare. What do you think the next steps are as a community to move toward value based healthcare? I know you mentioned AI as one of them. Are there any other, I guess, steps that you think we should take as a community?
Well, I think it would be great, and one of the things I'm really committed to is doing as much education as I possibly can about what is value based healthcare, the true definition, and how it should work. But also, I think that we need to be having more conversations about it. So that's what one of the other things I'm committed to is, when I'm out at an ACHE meeting or a HFMA meeting or some other meeting with clinicians, I always try to encourage the conversation about value based healthcare, and what are they doing in the area of value based healthcare, and what issues do they see, and how can we possibly all work together to resolve those issues. So I think that's definitely one of the big steps, is to have the conversations. Do the education, get everybody on the same page. And I do think, as we mentioned earlier, there's a lot of opportunity for technology. There's a lot of opportunity for patient reported outcome measures, remote patient monitoring. But the thing with that is, in any of this technology, is if you're going to incorporate it, you're going to get all this information, but you need to do something with it. You need to incorporate it into your clinical care, because, a lot of systems went out and did all this remote patient monitoring, and they get all this information and they don't really know how to integrate it into the clinical care. So I think that's something that we really need to work on, and also the systems are beginning to realize that they really need early in the process some governance around these things. You know, how is this technology going to be used, so we use it responsibly and effectively? So I think those are really big things that are happening now.
Yeah, that's a perfect segue to my next question because I wanted to touch on sort of the medical education side of your organization. I know you're involved with KOL management, some healthcare partnerships, and I guess this sort of medical education can provide this knowledge and can help people govern their practices, sort of figure out the why we're getting this information, how we can implement things. Do you feel there are any instances in your early career that sort of motivated you to focus in this area?
Yeah, as part of my just natural scientific inclination, throughout my life, and from my early career when I worked in the teaching institutions, and the clinicians embraced me because they understood I wanted to be a partner to them. It really fostered my love for interacting with clinicians and understanding what they do and how they do it. And then that led me from an industry perspective to think about how can we work with the clinicians that are doing great research and bringing innovative things to the market, to share that information with other clinicians, and to work with the medical societies, so that as an industry partner we could support these kind of activities, with them through the medical society, or even as a company through independent research grants, investigator initiated trials. That's a mouthful. And just things like that. So it just naturally evolved, and I've always gravitated toward key opinion leaders, especially the ones that are on the cutting edge of research, and bringing forth groundbreaking accomplishments, or even just sharing a new way to do something that everybody else has done a certain way in the past, and all of their clinical evidence to support that.
Earlier in your career, you were involved with medical sales. I was able to talk to some people, and they sort of had this opinion that sales representatives are more focused on pushing medications to make money rather than focus on the care of the patient, since they're usually given some sort of incentive based on how much money they make. What are your thoughts on these sales representatives sort of focusing on the money rather than the actual care of these medications? Do you feel as if there's a great amount of medications being prescribed that aren't necessarily needed just for the money?
I've never looked at it that way. I mean, there are people, without a doubt, that are in the industry to make a lot of money. But those people's, if that's your primary motivation, if your motivation is not to support the clinicians and the patients to give better care and have better outcomes, then you usually don't last in the industry, because clinicians are obviously very savvy, and they want to work with people that have the same goals that they have, which is, to improve outcomes and improve the efficiency and effectiveness of healthcare. And if you're only motivated by money and all you do is push, 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 and really don't try to understand them as clinicians or how you can work with them to help them support their patients, I mean, you're really not going to be successful in the industry. And luckily, it's been my experience that those people don't last very long, and it's a very small percentage, of people that actually are in medical or pharma sales. So many of the people in medical or and pharma sales are just like I was. They've always had a strong interest in science and in medicine, and they felt like they could support that better from an industry perspective, than actually delivering the care themselves.
Right. And I think trust plays a huge factor in healthcare. If you lose patient trust, or if you're not able to develop this trust between another provider and yourself, nothing will go anywhere. There would be no care, and all this care that is provided would be sort of it would be untrustworthy. People wouldn't want to go through it, and that would be a huge break in the healthcare system. You touched on transparency before. I think it's very important to mainly focus on that, what it really matters, and like you said, value based health care.
Yeah, and that's a really great point because it's been my experience that you have to develop authentic relationships. Especially with healthcare professionals, because you're right. Everybody that walks in their door is not going to have their trust and is not going to develop an authentic, strong relationship with that clinician. You really have to earn it. When you're on the industry side.
And sort of a related question, I've come across some individuals in the past who believe that, I guess, people overseeing clinical operations without clinical experience shouldn't necessarily be directing clinical operations. So, say, I know you were thinking about medical school, you were thinking about MBA, you end up going with MHA. Someone that only has an MHA or an MBA, do you think they should be able to direct clinical operations without, I guess, I can't say no knowledge of clinical operations, but more so no practicing clinical experience?
That's the one of the things that we really haven't touched on yet with true value-based healthcare is that you do have an integrated practice unit. So you have a multidisciplinary team that's involved in delivering the care over the continuum for a certain medical condition. So obviously, clinical operations is something that's very strong in that delivery chain, as is IT or data analytics or any of those things for people that aren't clinical or finance. They don't have clinical expertise, but they're critical in ensuring that you have a strong value based healthcare delivery system. So I think that, someone with strong clinical operations that's not clinical, if they have that operations expertise and they're working as a team with the other clinicians, I think they're naturally going to learn more about the clinical, and they're probably actively going to seek out learning more about the clinical. But it's really all about the team working together. So I don't have that bias. I mean, I can understand why certain people would, but I think there's a place in healthcare for everybody, and we all need to work together and use our strengths, to deliver those quality outcomes at a lower cost.
Right. And it's very difficult for someone to be sort of a master of all, And given how vast healthcare is and the amount of different skills required, it is important for, I guess, someone to be a master of one thing and someone else to focus on being a master of another and working together rather than someone sort of being a jack of all the trades, but not a master of any of them. I think it's
Right,
very
right,
important.
exactly. Yeah.
Yeah. So I have one final question. How do you define the success of Edwards value based health and where do you see it going?
For me, the success of Edwards value based health is at this point in my career. I don't know that I'll ever retire, but let's just say I'm entering my final stage. My goal is really to train as many people as I can on what really is value-based healthcare, as we've been talking throughout this program, and really have those conversations about how can we all work together and how can we improve our care and get the patients involved and implement our technology and really ensure that we're all working together. So my gauge of success is, how many people am I training? How many conversations am I starting? I mean, I can't tell you how much energy I get from going to an ACHE meeting and having conversations with the current students in the MHA and DRPH and PhD programs, or an Healthcare Financial Management Association meeting and talking with the students there, and the practicing clinicians that are engaged in all of these societies. It's incredibly energizing for me. So if I can use my efforts, on the value-based healthcare side to do that education and facilitate those conversations, that'll be successful. And then on the medical education side, if I can help companies that are struggling with how they support, providing the right clinical information and clinical evidence to their clinicians, that's really going to help improve outcomes from an industry side, I'm all about that. And how can we do key opinion leader management so we can get those thought leaders working with the companies to improve the current products and design new products? And I'm a firm believer that, medical societies play a key role in healthcare, and by facilitating the interactions among the clinicians to stimulate that improved care, and also, working with industry to support, the industry resources that can be provided in that area. So that's what I'm looking at for Edwards Value Based Health, is how can I do all of that? My primary motivation is really to leave healthcare in a better state than when I started in this industry. It's really always been my motivation in whatever job I have. So that's what I want to use my final years out here to do.
Yeah, no, that's really fantastic. I'm really excited to see where Edwards Value Based Health goes. I'm sure it'll reach great strides. It's definitely an organization to keep an eye on, and they definitely have a great leader backing it. So I'm really looking forward to see the great things to come. Thank you so much, Nancy. It was great talking to you today, and yeah, I think this is fantastic. I really thank you so much for sharing your knowledge on value based health and medical education. I think this is really a very good talk and is very important for our industry.
And thank you so much for the opportunity. I really appreciate it.
Of course. All right, take care. Bye bye.